We are going to today go through some more root operation challenges where you guys get to have your input on what you think the root operation is. Because honestly, in ICD-10 PCS coding, this is the biggest struggle that coders are facing right now, even in the real world, for coders who have been coding for many, many years. So having a basis of what is going on with these is, the best, what word am I looking for? The best knowledge you could have. So we're going to go through those. We're going to go through the coding roundtable. And actually at the end of the slideshow, there is some examples like we went through last week. So we're going to do that. And then I'll answer any questions you guys have. So are you all ready to get started? If you don't have any questions, then let me share my screen. Give me 1 second. All right, so our first root operation challenge is heart transplant. What do you guys think the root operation is? Very good. You guys, this one is one of the easier ones, but good job. And again, if you haven't watched live lecture before and you think I'm going fast, I apologize. What you need to do is go right above the chat box. There's a files area. You click on the file and then you download the file and you'll get this presentation. And at the bottom where I've hidden, it gives you the answer. So you can always go back through and, practice, but it's good to have it where it's, you're not cheating. So try not to cheat. Okay. So next one is herniorrhaphy, which is basically a hernia repair. They're repairing a hernia. Good job. Yes, it is repair. And that probably because I told you it was repair, but that's kind of where your medical terminology comes into play too. Where we learned all the, that it's hernia, and then raphy, or however you say that by itself, is repair. Fulguration of a rectal polyp. Any thoughts? Think of lasers, think of, that's basically what they're doing. I'm just waiting a minute. I see a few of you have it right. It is destruction. That is what fulguration means. It's basically a destruction of the rectal polyp. Okay, this one's an easy one. Cortical mapping. Yeah, that one's easy. Some of them are very easy, and then you have other ones like the fulguration. And once you understand that that's what those words mean, that when I think of fulguration, immediately my mind says destruction. Once you kind of get in that mindset, it becomes a lot easier. Okay, facelift. When you have a facelift, what are they doing? That's correct, alteration. Okay, urinary catheter change. Yeah, that one's an easy one too. It's change, you guys are right. Okay, partial nephrectomy. I'm just waiting. Excision, excellent. That's right, because when it's an excision, versus a resection, the excision is just a partial, not meaning the full body part. You're just doing a partial one. Carpal tunnel release. Another easy one, yeah. Unfortunately, not all of them are this easy. Exploratory laparotomy. Sharon, I wish they were, trust me. Good job, it is inspection. So let me explain something about an exploratory laparotomy. A laparotomy is how a person, or not how a person, but how a physician, when they cut open the belly and they open the patient up, if they just go in there and look around, that is an exploratory laparotomy. That is, and I will answer your question on inspection versus mapping in 1 second. And I apologize about my dogs. There's dogs outside, and we just moved into a new house. Okay, so let me explain the exploratory laparotomy, and then I'll explain the inspection versus mapping, and then I'll explain with the ostomy. And actually, Amanda, it's otomy. It's not an ostomy, because if it was an ostomy, it would be like a colonostomy or a colostomy. It's just an otomy. So this just means they're opening them up. That is it. So if they open a patient up, which means they're cutting down the belly, and I'm doing that with my mouse to show you. So they're cutting down the belly. They just open the patient up and look around. And that's all they do. That's when you would code an exploratory laparotomy. If they open the belly up and let's say they do a liver biopsy or they do a colectomy, then in those cases, you're going to code, the laparotomy ends up being, you don't code it. It's just how they got there. So that's what, you code an exploratory laparotomy if they do open the patient up and do nothing else. It's very, very rarely coded, honestly, because it is basically, if the one time that it makes me think about it, yes, nothing other than opening up is done and looking around. They're looking around. So Sharon, yes, it does become it becomes that. In this case, it would be that it's open. So that is, it would be the approach. So if they do anything else other than look around, then it would be the approach. That is correct, just like the colonoscopy. So let me go back to, give me 1 second, the inspection versus mapping. Hold on, I have to scroll, so give me 1 second. There we go, inspection versus mapping. So with inspection, they are basically just looking around, and that is it. They are looking to see what is going on. With mapping, it's more of almost like if you think about an EKG, that's more mapping. It's where if they do cardiac mapping or cortical mapping, the definition of it is locating the route of passage of electrical impulses and or locating functional areas in a body part. So if you think about electrical impulses, you're not going to have that if you just open up a belly and look inside of it. But if you have, monitors on the brain and then, they set it up to see, okay, are you having epileptic seizures, that type of thing. So that's what that means. Does that help? And I'm just waiting on typing. That's it. Okay, I'm going to move on because no, that it's not coming up, whoever's typing. So, skin pedicle flap transfer. What do you guys think on this one? I'm here. I'm just waiting. I see a lot of typing, but no words are coming up. And don't make, this one's actually easy, so don't make it harder than what it is. Are you guys still there? Okay. Okay, I just got bombarded. It must have been a delay because I'm like, okay, what's going on? Okay, transfer. That's great. It like literally 20 messages hit. Okay. Crazy. So when I have an EEG, that's considered mapping. Alicia, there's mapping and then there is monitoring, and it has to do with the extent of time that it goes on. So let me pull out my cards real quick. Let me see if I can find monitoring. I just moved this weekend and I apologize. Literally, I found all my cards in one drawer. The movers had dropped them all and threw them in a drawer. It's been a nightmare. So give me 2 seconds. Removal, alteration. And I don't even know if I have all my cards. But yes, it would be considered mapping. That is what it would be. So it depends on if you have it over a period of time versus a one time they check to see if you're having, if you think about like a Holter monitor, that is where it is, they check your heart, and they have the Holter monitor is literally on you for days, weeks, months. That's more of a monitoring versus a mapping, which is basically a one-time shot where they're doing the EEG. Okay. Okay, wait, I'm sorry. I'm back down to reading all the messages. I'll tell you what, this computer. Okay, so let me get back to where I was. And we will do a total lobectomy. Sharon, why is it not excision again? Because with a transfer, what they do is they are actually not excising it off the body. They keep the blood vessels going, and let me think of a place. Let's say there's a defect on your nose, and they will cut a piece of your forehead and then bring it down, and they will keep the vessels intact. And so then they will attach it to the nose, and it will then grow there. So that's how it's done. And that's why it's not an excision, because they're actually transferring it. And you all are right on the resection. Yes, that's correct. It's just being moved. You really don't want it. My brain, it goes way in too many directions. Okay. Adjustment of a prosthetic, or hip prosthesis. It is revision. Very good. It is revision. That one's a little bit more difficult. That's where you kind of have to go, yeah, what are they doing? Yeah, so let's say somebody has a hip prosthesis in there, and it's already in there, it's already in place, and let's say it slipped a little bit, and they want to bring it back into appropriate position. So it's already there, they're just trying to make it better because maybe it slipped, or maybe it's that's where you see it the most. That's why I keep saying that. Or maybe it's, rubbing them wrong, literally like the ball and socket, maybe it's rubbing and it's causing a lot of pain. So they're going in to revise it, to make it better. So think of it like that. Does that help? Yes, they'll determine what's wrong prior to even going in there. So, they'll do x-rays or whatever, and they'll say, okay, this hip is, the socket is out of place, or, it's, even if the patient says, it's just really, really, really hurting me. And so then they'll like, okay, we'll go in and we'll make it better. It's almost like if you go, with anything that you go in to make better, if it's not perfect, something's not perfect, and then you go in and revise it and say, okay, well, it's like a report even, you're making you've gotten your feedback on a report, and it's like, you know what, this isn't, these are the errors I found, and you go in and revise it. Think of it that way. Okay, fracture reduction. You can purchase the cards from a HEMA. Just go to HEMA.org. You all are close, but not. Y'all are choosing the easy reduction part. When they reduce a fracture, think about what they do. Okay, so I know I mentioned this last time. They take the, they're in the ER. They take your leg that you've broken, and let's do the ankle, where the ankle's like jacked and it's off to the side, and then they straighten it and make the bone straight. They're repositioning it back to where it was, so it is repositioned. They're making it go back to where the normal area that it is supposed to go to. Okay, coronary artery bypass. Yeah, this one's an easy one. And then in real life, this is called a cabbage, by the way. CABG. They usually do, if you ever heard of somebody saying, I had a 4 bypass, or, 3 bypass, 6 bypass, what they're doing is they're taking the arteries, it stands for graft. They're taking the arteries in the heart, and they usually use a mammary artery, and they will take it. That's one they usually use. Usually it's one mammary, and then they will take the other arteries, and basically it's almost like they say, okay, well, this artery's good and this one's bad. We'll take this bad part out and make this part good. Yes, a quadruple would be 4. I've seen a 6. That's the most I think I've seen. But, it ranges just on how bad their heart is. And so, they just take that one bad, if one artery cannot be dislodged by what's called a PTCA, which is a percutaneous transluminal angioplasty, which is, if you think about where they stick the wires up your leg, or the and then they put, I was trying to think of the technical term, and then they put the, it has the balloon on there, and then they put the balloon on there and, expand it, and it usually breaks up the clot, or they'll put stents in there, and so the blood flows better. If it cannot be done that way, then that's when they do a bypass. Okay, free skin graft. And a graft is not a transfer, and a graft is not a, I'm just watching, seeing what you guys are getting. It's actually a replacement. It is they are taking the graft and putting it onto a whole other area of the body. So if you think about a burn patient, and they take their leg skin, and for example, this is just an example, and they cut off the whole skin, all the skin, and then they put it, let's say, on their back or on their, chest or someplace that needs it. They're replacing that skin with the graft. Does that make sense? Oh, wow, Margaret. Sharon, actually, it's replacement. Oh, it's not supplement, but it's replacement. Yes, that's correct. That's you're taking good skin and using it to replace burnt skin. So that is a replacement. Okay, mitral valve ring annuloplasty. Plasty does mean repair, but, and some of you guys answered this with the other ones, with the other one. What this annuloplasty is going to do is take the place of this mitral valve. And I'm just waiting on a few more answers. It is supplement. That is correct. It's taking the place of. Okay, so restriction. Oh, see, I gave you the answer. I was looking at my sheet and then just didn't, yeah, you got that one. See, that's so me. Okay. So, esophagogastric fundoplication, I couldn't get it out, is restriction. Thank you, Professor McCollum. You are special. Okay. Oh. Cardiac pacemaker removal. That one's easy, yes. Pyloromyotomy. And I'll explain this one after I see if you guys get it. So babies can be born with what's called pyloric stenosis. And basically their pylorus is very, very constricted. And so they puke, and I mean like a projectile against the wall puke. And what they'll do is they go in and they dilate the stenosis and make it bigger. And so that's what the pyloromyotomy means. They're going in, making that bigger, making it dilated. Incision and drainage. That one's an easy one. Yep, There you go. That one was easy. Okay, spinal fusion. Another easy one. Yeah. Okay. Ligation of inferior vena cava. Remember, ligation means to basically to cut it off. They're tying it up. It is occlusion. Occlusion. Marsha, I'll be happy to help you with whatever anatomical questions you have. I will go through some of it and see what, if I can, if I can cover what you have questions on. Okay, so choledocholelithotomy. So with a choledocholelithotomy, this is where a person has stones in their gallbladder and in their bile ducts, and they take them out. Not by lithotripsy, they go in and take them out usually with a some sort of bag, or well, they have a bag in there. It's usually done laparoscopically, and they will take them out and put them in the bag. Holly is correct. It's extirpation. So a stone is not connected to the body. So unlike a polyp, it is not connected. It can move, it can go in and out. It's it's kind of like food. So if something is not connected, it's considered extirpation, such as with thrombus, such as with, if it's an embolism, anything, blood clot of any sort, because it can move up and down. It's not connected to the body. That's what makes it different. Okay, a few more. Osteotomy. This is kind of what we dealt with, kind of. Well, we didn't, no, that's not true. Osteotomy. Division, that's correct. Okay, vein stripping. So vein stripping is basically where they take the veins and pull them out. There you go. Yes, it's extraction. Creation of a penis in a female. Creation. There you go. All right. Control of a post-tonsillectomy hemorrhage. Good job. Yeah, some of these are easy. Reattachment of an avulsed kidney. There's no reattachment. That's not it. No, it is reattachment. My bad. I'm looking at a different thing. It's been a very, very long day. I'm sorry. It is reattachment. Transurethral lithotripsy. Yes. Fragmentation. This is where they destroy the different types of stones. Disarticulation of the shoulder. That's correct. So they're not necessarily, when you think of detached, to me, I think of almost I don't know, I almost think of amputations, and that is what it is, but, and we're going to see that today. Yes, so it is, they're, in this sense, they are, you don't see cutting off of the shoulder that often, so maybe that's why I'm not following that. I would think of this as more of a, below the knee amputation or that type of thing. So, insertion of a radioactive implant. Oh, so what's the answer? It's detachment. I'm sorry. And yes, it's insertion. Okay, well, I don't want to, I definitely want to cover everything. So let me ask you this, for the anatomical regions, what can I do to help explain something? I don't want to not cover that. It's, Marsha, if you can, the amputations. Okay, yeah, and we're going to go over the coding roundtable, definitely. So we can go ahead and do that now, and then I'll go back. You know what? I wish there was an easy way to remember the anatomical regions. It's kind of, to me, is, it's across the board. I mean, it's like, I don't know, which, I don't, there's not really any cut and dry, okay, this is how they've done it, this is how they've set it up, that type of thing. So, Alicia, on which scenarios to code? Okay, and then Jennifer, bypass. Okay, hold on, let me make some notes real quick so I can... just let me know, Alicia, let me know what scenario you're talking about. Bypass I can definitely, look at. Let me go into 3M real quick. I'm going to go into the iLab, and so those of you who are here all the time, just ignore me, but some people have not heard me before. I know they're missing out so much sarcasm in my voice. So you click on this lab.devry.edu, and then you put in your D number. And yes, Jennifer, I do too. And I'm not a fan of any other one. So give me 1 second. It seems like it's being a little slow. Will you be my friend? Yes, you will use you will use it more than you use it here. Much, much more. So I don't know why I did it that way. It's nothing but dogs in this house, I swear. Okay, hold on, it's starting up. I am not close to Fort Hood. I'm in the Dallas area. I'm sorry. Are you in Fort Hood? Are you serving, or is your spouse serving, or significant other serving? Oh, tell him thank you for, or her, thank you for their service. I appreciate that so much. Okay, so we're going to do it this way. I've never heard of Nocona? Okay, let's see. Let's do... You know, I was born and raised in Tennessee. Born and raised in Knoxville. Huge Vols fan. Huge Vols fan. Oh, okay, you were raised in Clarksville. Okay. I lived in Nashville for many years. In Burleson, that's where Kelly Clarkson's from. One of my favorites. Okay, let me see. You'll be in my mind and it'll just ADD and then, yeah, here we go. Okay, so we'll just look at the bypasses first. Both my parents graduated from Vanderbilt. My father was a physician, my mother was a nurse. Okay, here we go. So we have bypass. Are we talking about the coronary, pulmonary, or the heart, basically? Like a cabbage, see? Notice the cabbage, that's what they call them. I'm so sorry about the dogs. There's obviously another dog outside, and I totally apologize, trust me. There's no blinds on my house. It's insane here. Totally sorry. Okay, so so if you click on the little question mark, so what they're doing in a bypass is altering the route of passage of the contents of a tubular body part. So, basically they're taking one tube and putting it to another tube so that it will flow smoothly. That's the point of it. So if they're doing a cabbage, so the next thing that they are looking at is where is it going to? I'm sorry, here, let me move this. Is it going from the coronary artery coronary artery to coronary artery? Is it going from coronary artery or the mammary artery to the coronary artery? Or is it, where is it going? So, okay, so here, most of the time, here's what we have. You usually have, let's say they do a ×4. It is a internal mammary artery, usually, whether it's the right or the left, to a coronary artery. So you can choose this first. So we'll just say it's of the left one. So, they want to know, okay, coronary artery, is it one site, two sites, three sites, or more sites? This is where, how many coronary arteries are being bypassed? You have to really dissect they're going to talk about, not internal mammary arteries. These dogs barking are making me insane. I can't think. Going to talk about the different types of coronary arteries. And then, so is it, how many sites are they dealing with? So we'll say it's two sites. We're going to say it's open. We're going to assume that they're doing a cabbage. I haven't seen a cabbage done percutaneous endoscopically. I left the PowerPoint. I'm now just looking at, somebody had a question about bypasses, so that's all I was doing. So I will get back to the PowerPoint in just a second. But with okay, what is, Sharon, I don't have the book. Okay, hold on, let me pull the book up real quick because I have it online. Okay, so chapter 5, question 11. Thank you. Okay. I need chapter 5, not question. Let's see. And chapter 5, question 11. Thank you. I appreciate that. 123. Okay, that's not coming up that way. Hold on one second. Let me try it this way. All right, I'm obviously being special here. I just need to go back to the beginning. I know, I understand. Oh, here we go. It was what was it, 123? There we go, thank you. Okay, up your left bundle, complete heart block. Procedure. Left chest was prepped and draped in the usual sterile fashion. Let's see. That's not the right, that one is, that's obvious, oh, right above the scenario, okay. I'm just looking. Is there, oh, number 5. The colostomy? Question 11, okay. Here we go. Patient undergoes open coronary artery bypass graft surgery, left internal mammary artery to the LAD, left radial artery graft from the aorta to the posterior descending artery, and the left greater saphenous vein graft from the aorta sequential to the diagonal. Okay, both grafts are harvested using the percutaneous endoscopic approach. Okay, well, we're going to use the percutaneous endoscopic approach. Not that I've ever used that before in real life. Okay, so here's what we're going to do. So the patient is undergoing a CABG, so we're going to type in CABG. And they're first off going from the left internal mammary artery to the LAD. Okay, so coronary artery bypass, select lesions treated. This one is going to be, let's see, they did 1, 2, well they did, yeah, 1, 2, it's 2 different ones, it's 2 sites, minus the mammary artery, and that was percutaneous, no device. They did do coronary artery, wait, let me go back, because that's coronary artery 1 site, percutaneous endoscopic, and then no device. They did coronary artery to coronary artery, and this one they did 1, let's see, hold on, radial artery graft from the aorta to the posterior descending PDA. So we got that one to that one, and then that one from the, okay, so 2 sites, no device. Let me make sure I did no device. And then, you know what, let me go back because I chose the wrong thing. It's aorta to coronary artery. So from the aorta on both sites, so they've got 2 sites. Make sure I got that right, 2 sites, okay. So is it the radial artery? Give me a second, I'm just reading through it. Okay, left radial artery from the aorta to the posterior descending PDA and the left greater saphenous vein graft from the aorta. So this is going to be you don't talk about the radial artery. Okay, then no more number of, oh, this is just one, that was ICD 9. Continue, okay. So, let me make this big again. You have bypass coronary artery, one site from the left internal mammary to the, which is percutaneous endoscopic. Then you have bypass coronary artery, two sites from the aorta with the arterial tissue. Does that help at all? I know I had to read it to make sense. No, it will not always be from the coronary artery. You're bypassing the coronary arteries. It can come from the aorta, or it will come from the mammaries, or it may come from another coronary artery. Yes, Tracy, coding is very, very, very hard. This is the grafts. This is the the bypass is the grafts. You're bypassing the arteries. Any other questions on, I mean, I'll be glad to help with the, anything with the anatomical or, that, hold on. Now, there is 3 bypasses and 2 excisions in the answer. 2 excisions? Yes, I'm going to do the amputation. That's what, you're saying the answer has 2 excisions? Oh, because they did the harvesting. Yeah, it's because of the harvesting. I didn't even read that far. So harvest, I'm sorry, I'm using let me go back. And I didn't even see let me minimize this. Both grafts are harvested using the percutaneous approach. The saphenous vein, thank you. And I can't spell. Okay, saphenous vein. Left radial artery graft from the aorta, passing the left from the aorta. So we have the left greater saphenous, and that was percutaneous endoscopic. It was for harvesting. So you have excision. Alicia, I have coded 15 procedures out of one operative report. There's never gonna, well, okay, there will be occasionally one per one report, but it's not that often. So we have excision of the left greater saphenous vein. We also have harvest of the left radial artery. Do we have left radial, radius ulna? Yeah, I was having a moment. Left radial, there we go. Percutaneous endoscopic. I don't like how this I9 does this. Yeah, okay, hold on. Let's see. So for the question, yes, the radial excision is done to, so we don't code where the artery is being attached to, it's yes, where it's coming from. That is correct. Why I-9, that's just how 3M, when we had to dual code back before October, they had it set up this way, and it just hasn't been updated yet. You thought the qualifier was attached to, hold on, let me back up. So there, the modifier is there. Oh, no, you only attach modifier. Oh, wait, the qualifier. I thought you said modifier. The qualifier is there. It's the Z. There's not a qualifier. I don't, Holly, I wish I knew a way to skip it. I'm going to say no, and then, you know what, let me go back and just write this code down so I can, BC4ZZ. Nope, I don't really want to exit. O3BC4Z. What do you mean it's not allowed? Oh, I must not be far back enough. Well, it's not letting me do it that way. It's O3BC4ZZ, which is excision of the radial artery. Marsha, what, as far as the qualifier is there, it's the 7th character. So what qualifier did you think was attached? Oh yeah, it's 03B as in boy, C as in cat, 4 as in 4, ZZ, zebra. Okay, so let's look at the coding roundtable just because you wanted to also look at amputation. So let me pull that up. So here they're doing a below the knee amputation. And with below the knee amputation, the one issue that you're going to have in this is the qualifier. Because you need to know where the tibial tuberosity is. And again, I know that I showed this to you before, but I highly recommend that you guys go into right here where it's the stack of books, and it's pulling up on my other screen, and look at the anatomy plates. And you can look at the musculoskeletal, and you can look at, let's see, where are we going to find it here? I think knee is just the knee, yeah. So I may just have to go into the actual, let me see. Oh, here, the skeletal system. It's not going to show me there. Let me go back again. Okay, I proved myself wrong in this case because it doesn't have the, yeah, that's what I was getting ready to do, Jennifer. So under Google, tibial tuberosity, and I spelt it wrong, but they seem to know what I meant. There we go, tuberosity. That was funny. Okay, so here, let's look at some of the pictures. We'll look at some that have, it's not a good one. Yeah, that's where the tibial tuberosity is. There it is. I was trying to wait for the words. So the tibial tuberosity is very, very high up on the bone. So you got to remember that up here, this is high versus low, and this is medial. So here is the, Tracy, thank you for that. Yeah, they are back there too. So here's your high. This is considered high. So that's, if you don't know where something is, I mean, Google is my friend. I was hoping to be able to use, the one where it was, where I could show you all the books, but that just didn't prove. It shows the tibia, but, well, there it is, the tibial tuberosity. There it is right there. So you could look it up there. So we have they're doing a amputation. Oh my goodness. There we go. Again, it doesn't matter. Oh my goodness. It doesn't matter what sex or age the patient is. I mean, everybody has legs. So it's, in this case, it doesn't matter. So I'm just going to keep it a female, and I'll make it 56, and do code finder and procedure. So you don't have to code the Foley cath. That's included. They cath everybody when you go into surgery, and that's picked up by the charge master. And this is basically, it's located below the tibial tuberosity anteriorly. And yes, so it is still considered high. So middle would be much, much lower. I mean, you would be like in the middle of your shin. But if you just type in BKA for below the knee amputation, it will ask, okay, is it right or left? We're going to do right. And so here it gives you, if you click on the little question marks, it's going to say amputation at the proximal portion of the shaft of the tibia, fibula, or radius ulna. So, and then, of course, mid is mid amputation in the middle portion of the shaft. That's when you're going to know. I mean, in all honesty, most BKAs are high. I mean, they don't, if they're cutting off the foot, that's a whole, different thing. But it's, this is considered, a below the knee amputation. So in this case, it is high. It's a below the knee, and that was just for I9 purposes. So you have detachment of right lower leg, high, open approach. OY, 6H, yes. Oh, OZ1. Alicia, it's the qualifier is 1 on this one. And that's the only code. There's only one code. That is all it is. No, you don't have to code the blood transfusion, and you don't code the bladder drainage. The blood transfusion, okay, let me talk about the blood transfusion. And then with the catheterization, this is picked up by the charge master. This is where they do this to every single patient. So what what you need to know from this is you don't ever code that. The blood transfusions, this is where from I-9 to I-10, it really changed. If you go into 3M and try to code, because what they'll say is, what did they say? Patient received 1 unit of packed cells. In I-9, yes, we could code that. But if you go now and look at it, so transfusion, and we're going to do packed cells wherever they are. Why am I not seeing them? Okay, hold on. Yeah, it's taking me to see. Oh, red blood cells. I was having a moment. Okay, there we go. We don't know. See, we need to know, is it given? Yes, Janice, you can code red blood cells. It is, but the problem is we don't know if it was given, if he donated his own blood, if it was given by somebody else. So we're already at our first stop. We have no idea. So what most hospitals have done is the charge master picks these up. Yes, it is picked up in the charge master, so we don't have to code these anymore. I've worked in places where they wanted every single blood transfusion coded. I've had to code like 30 blood transfusions in one visit. I've had, where they say, okay, code it once. I've had some say, don't code it at all. The charge master, okay, hold on 1 second. Let me just make sure I answer all questions. I will go over the qualifier 3 again. I will look at the book. And the charge master is where they have the CPT codes for procedures that don't require a brain to think about what's being done. So single view chest x-ray, anything in the lab, anything like that, blood transfusion of packed cells. These all have a CPT code that anybody, if you say, okay, type in this, then that goes to, it's attached to the charge and it's attached to the CPT code. So that's what the charge that's kind of in a nutshell. It's a little bit more, you can definitely Google it and look. Yeah, so no interpretation, that's correct. And Alicia, that's correct. Think about high as higher up to the body, higher to the head, with low being further to your feet. And I will, yes, so, all right, here we go. Let's see, hold on, I'm trying to find the question. Hold on. Okay. So here we're going to go to procedures right there. You're not going to use any of these other ones. You'll use those in 205. You click right here. So either A, if you know which path you're taking, you can just click on these, but I'm going to do amputation. And see, it automatically says see detachment. So click on detachment, and either you can scroll down and find the knee, in which I don't remember now. That's sad. I don't even remember if it was the left or right knee. So hold on. Right. Okay. So we have the knee region right, but see, if you just do this, it gives you the wrong code because it says no qualifier. It doesn't even give you the option. So let's do detachment. And it may not even allow me to do it. Interesting. Leg, lower. Oh, here we go. This is where the whole anatomical region comes up, because we're going to use leg instead of knee. So leg, lower, right, and then it's going to ask, is it high, medium, or low? So the high is because it is up closer. So that's how you find it on that one. So here is where it becomes a more generalized area with amputations. That's kind of, it's a generalized region. Okay, let me see if there's... I'm just looking at... I'm glad you got it. Is there any other questions that I can answer for you? Yes, so the intent of the procedure is the amputation. That is the intent. They're going in to amputate. With the forehead flap. There we go. Closer to the head is higher. Perfect. Margaret, some days it's scary for me too. I use skin and breast with the forehead flap. Was it a certain question? Oh, skin and fascia. Yeah. You got to see how far they go down. If that's real important. So if they just do that very top layer, that's considered basically skin and subcutaneous tissue. But if they go down further, it's considered the fascia. It's not always cut and dry and easy to read, trust me. Yes, that's correct. It's detachment. And then it's lower leg, right lower leg, extremity, and then it was open, and then it was high in regards. Jennifer, you do, when it comes to diagnosis, it's it's a little bit different, but with procedures, you have to look at what all's included, in regards to supplies. Is there? Yeah, there's probably going to be coding on the quiz. Yes. It just takes practice. I would, just take it, just keep practicing. That's the only, it's, when I first started, I had no idea. Think of detachment as you are removing it from the body, like a whole body part, not just like a mole or a, think of detachment as amputation. That's the only way I can think of it to make it different. We don't want a heart attack. Yeah, I'm just waiting on the it just, you know, honestly, it just takes a lot of practice. And this is your guys' first class. You know, you still have 205, then you have CPT, which I think is still 211, though they keep changing the numbers on me. You know, just keep practicing. You know, when I started, in all honesty, I had a C. It was the only C I made, and was in coding. And I hated coding. And I said, I'll never do that. That's, you know, and then that was my first job. And, you know, I learned that it's kind of my niche. I understand it. So, you know, don't give up. If you feel it's what you're, you know, what you're meant to do, then, you know, yes, I see, Sharon, yes. No judgment. So, yeah, I did. It was my only C. But look, I mean, I've come a long way. I've been doing it 26 years now. So it becomes easier, trust me. Some days, I mean, I look at some stuff and I have to ask my coworkers, you know, what are your thoughts on this? This is the situation. This is, because if you think about every individual person, every single individual person is different. So one case is completely, you know, you may have the same diagnosis, but one patient is completely different than another patient. So, you know, that's the problem, is that if you're very, very black and white, you know, you need it to fit in a little box. Coding is not for you. You know, I sit at my desk, and though I'm in a different, you know, I do different things now than when I was coding, but you sit here for 8 hours, and yes, you can email me and CIADD. Oh, that's the wrong ad. So, you know, I see now ADD, and I forgot what I was talking about. That's part of getting old too. You know, my point is, you know, just make sure that if this is what you want to do, you know, if it's your desire, don't do it because, you know, you think you're going to make money, or you think that, you know, whatever. Do it because you really like to do it. I mean, I sit here all by myself and, you know, in silence, minus the dogs barking, you know, 8+ hours a day. So, you know, just, you know, and don't worry about the dean's list. I didn't have the dean's list. So it is like a puzzle, and you have to like terminology, and you have to like medicine. You have to find that very interesting, and, you know, what are they doing and why are they doing this, and, you know, that type of thing. So, you know, you guys hang in there. It's going to be fine. If you do need me, email me. I was very, very bad. I moved this weekend, so I didn't check my emails till today. So I'm very bad. But I left my email up there. You guys send me an email and have a, you know, a great week. And, you know, if you need anything, email me. I promise I'll check my emails this week. It can be done from home, Margaret. You know, just, it's not everybody's meant to work at home. That's kind of the thing too. You have to be very dedicated and willing to, you know, focus your time on that. So, oh yes, thank you, Jennifer. Yes, thank you. So, thank you guys. Have a great evening.